So today we're going to be talking about administering emergency oxygen. I've decided to do an online lecture so that we could spend more time in the lab actually using the tools that you will actually be applying to your patients. What we know about oxygen, at least the administration of oxygen in the healthcare field, is that it's most often prescribed or administered for hypoxemic patients, right? Those patients who are struggling to get oxygen into the body. And so the goal of oxygen therapy then is to increase alveolar oxygen tension, or in other words, it's to increase the amount of oxygen that the patient is breathing in to facilitate that process, right? And the other goal is to then decrease the effort of breathing for that patient, right? So to decrease the need for oxygen, which would hopefully improve the breathing condition. Although oxygen is principally a life-saving technique, in certain circumstances, it can become lethal if prescribed or administered incorrectly. And so that's why we do these trainings to ensure that healthcare professionals are using oxygen the way that is intended to be used in the field. So to ensure safe, effective delivery of oxygen, healthcare professionals dealing with the administration of oxygen therapy should understand the principles and really truly be justified in its use. I have seen oxygen in the field being used kind of as like an ergogenic aid. I put quotation marks around that. And in most cases, what I really want you guys to understand is that it should only be used in patients who really have some sort of breathing abnormality. So we're going to be certifying you guys through the Red Cross, and the Red Cross has its own standards, right? So when we're talking about breathing abnormalities, what we're really talking about, or for an adult, is that patient who is breathing fewer than 12 breaths per minute or more than 20 breaths per minute, right? So we're really thinking about is that person who is either hypo and or hyperventilating, right? For a child, it would be a child who's breathing fewer than 15 breaths per minute or more than 30 breaths per minute. And then for an infant, obviously a little bit quicker. So fewer than 25 breaths per minute or more than 50 breaths per minute, right? In either scenario, whether it's the lower end of that spectrum or the higher end of that spectrum, these all warrant the use or administration of oxygen in the field. And so now that we kind of have that standard, you all might be saying, well, what is considered a child versus an infant versus an adult? So an infant is considered anyone between the ages of 0 and 1. A child is then considered anyone between the ages of 1 and puberty, or if you want to put a weight on that, about 120 pounds, right? Because the reality is we do have children who are obese in nature, and so if that's the case, then we would use maybe a pound kind of threshold. And then an adult would be anyone that has reached puberty or is 121 pounds or greater. So hopefully that makes sense when you're deciding kind of how to treat your patients. This is kind of the Red Cross standards in terms of age differentiations between an infant, child, and adult. So let's talk about oxygen, because that's really what we want to kind of cover during our meeting time together. There are different types of oxygen delivery systems. So first of all, let's just talk about the tank itself, right? So the oxygen tank, I'm going to try to draw here, really consists of several different things. So the first thing that we have is the oxygen cylinder, which is this guy here. Most often it's going to be green in most cases, so it's going to be green. Or it will have a little bit of a triangle symbol, and it will say oxygen in that diamond symbol. Sorry about that. Then the next thing that we're going to have is a pressure regulator or with a flow meter. So that pressure regulator is going to basically attach to and have a handle on it here, and this knob can actually be turned, and this is going to be what we call is the pressure regulator with the flow meter. And then the last thing that we should always have associated with our oxygen device or cylinder is going to be a delivery device, and those delivery devices will vary depending on your site. Most often what most oxygen bags will have will be a nasal cannula, which is the most common delivery device for conscious patients, and then your non-rebreather mask, which can be used for conscious and unconscious patients as well. So the oxygen cylinder, as I've already said, is most often green, but it's going to vary in its sizes, and it's going to vary in its pressure, how much oxygen it actually can contain. And that's going to be dependent on where you order it from or what your physician actually prescribes. The flow meter and the pressure regulator, to me, is one of the most important structures associated with the delivery of oxygen, because it truly is going to control the pressure coming out of the oxygen tank and the rate at which you can actually deliver that oxygen. Keep in mind as we go through this lecture that a higher flow rate isn't always better. So I would say err on the side of caution and err on how your patient is able to actually respirate at that particular time. Most often, at least within the United States, oxygen units are available without prescription, which is great. I think you guys order your items through Amazon. It is true that you can order oxygen tanks off of the internet, provided the biggest caveat is that they have to contain at least a 15-minute supply of oxygen. That's just the standard recommendation from the FDA. There are two different types of delivery systems that you can encounter in the field. The first one is a variable flow rate, and then the second one is a fixed flow rate. As the names imply, one of them is going to allow you to adjust the rate at which oxygen flows, and that would be a variable flow rate oxygen device. The negative to this is that the device actually has to be assembled. So this pressure regulator here will have to be attached to the delivery device. Order it separately as well. With your fixed flow rate oxygen systems, these already come together assembled, and they have only one flow at which they flow out of, or only one rate at which they actually flow. So an example would be if you're searching the internet for an oxygen tank, you could purchase one that only delivers 15 liters per minute, only delivers 5 liters per minute, and there are bonuses and then there are negatives to this. The positive is you don't have to assemble it. The negative is that you only get one flow rate. So we'll learn in the next few slides that your flow rates dictate which type of delivery device can actually be used. So here are the most common delivery devices associated with oxygen administration. The first one is a nasal cannula. It's probably the most common type of delivery device and the easiest to set up by far. The biggest obstacle to setting up the nasal cannula is that something has to go into the patient's nose, and so sometimes if you're having a patient who's struggling to breathe, it might be difficult to apply the nasal cannula, but by far the most common delivery device used in oxygen administration. So the common flow rate, the rate at which we should deliver oxygen when we are using this device, is 1 to 6 liters per minute. So we can already see, like with the fixed flow delivery device, if that delivery device delivers 10 liters per minute or 15 liters per minute, then that automatically does not allow us to use the nasal cannula. One caveat with the nasal cannula in particular is that it increases the risk of nosebleeds. So the biggest thing is that we have to stick to this common flow rate. If we go above this common flow rate, then the risk of creating a nosebleed is really, really high for our patients. And then so what we know about the nasal cannula is it has the ability to deliver about 24 to 44% of oxygen to our patients. Now, who is this suitable for? It's suitable for conscious patients or patients with difficulty breathing, or patients who maybe don't like having a mask on their face. So example would be these next 3 types of devices we're going to talk about are going to be devices that actually go over the patient's face, right? The nasal cannula is the only device that does not cover the patient's face. So if you have a patient who maybe is claustrophobic or doesn't want anything over their face, then this is your only option. If you have a fixed flow rate device, you better hope and pray that it falls between that 1 and 6 liters per minute. Let's back up a little bit and say that what we breathe in terms of CPR and rescue breathing, what we can breathe into the patient is approximately 21% oxygen. So when we breathe into our patients, what we are breathing into them is approximately 21% oxygen in terms of oxygen concentration. So we can see that the nasal cannula is going to deliver just about that, or maybe even 2 times that rate. Either way, we're getting them more oxygen than they're capable of getting if they are hypo and or hyperventilating. Your resuscitation mask is a common tool that's used in unconscious patients most often, but it could most certainly be used in your conscious choking patients or your conscious patients as well. The biggest deal here with the resuscitation mask is it's probably one of the best tools to use to facilitate your CPR, right? Remember I said you're going to get about 21% oxygen concentration, just you alone breathing into the patient, but you can see with the resuscitation mask that you're going to get a lot more concentration. So if you can attach an oxygen tank to the resuscitation mask while you're actually doing that rescue breathing skill or that CPR skill, then it increases the concentration of O2 being delivered to your patient, and that's always a win-win situation. So with the resuscitation mask, it can be used with a device that delivers between 6 to 15 liters per minute. Again, if they are conscious, that 15 liters per minute, it is going to feel like someone is just blowing air in their face up close and personal. So you may start at that 6 liters per minute and then progress them once they're comfortable with the air being breathed or blown into their face. One, caveat here is that a lot of people assume that when you increase the liters being delivered per minute, that you increase the oxygen concentration. That is untrue. So if they are at a lower flow rate, they still get the 35 to 55% oxygen concentration. If they're at a 15 liters per minute flow rate, the same thing applies. So don't always assume that increasing the flow rate will increase the oxygen concentration. The amount of oxygen being delivered to the body really is going to depend on the patient's breathing pattern. So it becomes important not only to administer the oxygen, but also to make sure that you're helping your patient with their breathing patterns. The quicker we restore a normative breathing pattern, the sooner, the higher the possibility of increasing the oxygen concentration being delivered to the patient's cell. The next delivery device that we have is the non-rebreather mask. One of the things that I really like about the non-rebreather mask is that oxygen will sit in this little chamber here. And then when they breathe in, then it will be depleted. And as soon as they breathe out, more oxygen will fill in. And so because oxygen is sitting here, one of the great things about the nasal or the non-rebreather mask is that it is capable of delivering an oxygen concentration of up to 90%. So it's definitely ideal, right? But one of the biggest difficulties with the non-rebreather mask is, again, with all 3 of these, is that it covers the face. So if you have a patient who's hyperventilating, they really most often don't want something over their face. So you have to figure out how to put it over their face, how to calm them down, and how to get them to breathe in the oxygen. The other thing that you'll notice is different is the liters per minute increases. And the reason for that is because of the fact that air isn't blowing directly into the patient's face. It's actually blowing into the bag. So the patient can tolerate a higher flow rate. And then last but not least is the bag valve mask. You can absolutely use a bag valve mask on a conscious patient. I recommend, though, however, that it be used on an unconscious patient. Now, the reason for this is because of the amount of air that you will blow into that patient's face, especially a patient who is having difficulty breathing. So for me personally, this is my least favorite device to use during oxygen administration, but it doesn't necessarily mean that you shouldn't use it. Okay. With that said, there are some distinct advantages. Number one, it has the highest flow rate and it has the highest deliverable oxygen concentration of 90% plus. If you look at both the non-rebreather mask and the bag valve mask, however, up to 90% isn't bad. My preference would be the non-rebreather mask, again, because the air is going to fill here and there isn't going to be this violent influx of air being delivered to our patient. So prior to delivering or administering oxygen, there are some safety precautions that we probably should follow. And some of those safety precautions, they are listed here. I'm going to give you probably the top 3 that you should be concerned with. The first one is always checking the cylinder to make sure there aren't any leaks, any abnormal bulging, defective or inoperable valves. And I know that seems like common sense because we store it in our clinics, but it's always just a quick check as you take out the oxygen tank to ensure there aren't any abnormalities about it. The other is making sure that when you are administering the oxygen that you don't stand the oxygen cylinders upright unless they're well secured. So in some patients, we'll see this a lot in emphysemic patients where they have the little metal kind of wheelchair that they're carrying it in that it's secured to because if the oxygen cylinder falls and if the regulator valve either becomes damaged or comes off, it can actually, all of the pressure in that tank will be relieved, and it could basically lead to injury, right? So we want to make sure that if nothing else, we lay that tank down when we are administering oxygen. I think this is kind of a no-brainer, but no smoking, flames, sparks, etc. when you're administering oxygen. I don't think we'll encounter a situation where we have smoking patients, but in the event that we do, it should be a no during the actual treatment. These other things I'll allow you to read for yourself, but those are the key items that I kind of wanted to hit here. And then another big item is monitoring oxygen saturation. So most clinics will have what is called a pulse oximetry system. If not, you can order them for relatively cheap. These kind of help you determine whether or not oxygen actually needs to be administered. But then the awesome thing is, as oxygen is being administered, it allows you to look at the concentration of oxygen as you are delivering. So you'll start to see that 98%, it might actually increase. And so then it will allow you to decide when you need to stop treatment, if that makes sense. So pulse oximetry readings are recorded using a percentage, and then the SpO2 is kind of delivered to you. So I guess what I'm saying to you all is that you should have a pulse oximeter in your kits, in particular with patients that you know that you're probably going to have to administer oxygen to. Use it as a preemptive tool to say, is this something that I actually need to do, or can I allow my patient to just kind of breathe it out and supply their own oxygen concentration through normal breathing patterns. So one clinical tool that can be used in the field to kind of help you measure the percentage of oxygen concentration or saturation in the blood is a pulse oximeter. And so these little tools can be purchased for relatively cheap, but they're great tools to kind of help you determine when and if you actually need to deliver oxygen, if that makes sense. So pulse oximetry should be used as an added tool, but not the only tool, right? Other tools would be looking at the patient to actually see if they're cyanotic and or ashen, looking at breathing patterns, using the high and the low respiratory rates to help you determine that as well. But pulse oximetry is another kind of great tool to help you use to assess how depleted is the patient's oxygen based on their breathing patterns. And so let's take a look at this chart here. This is kind of the Red Cross's standard in terms of pulse oximetry. So the question really becomes, as a clinician, when do we administer oxygen? And so I would kind of use this table here to kind of help guide you. So a normal patient, what we know about a normal patient in terms of pulse oximetry is that they'll have between 95 to 100% oxygen saturation levels. So a patient who's in mild hypoxia, in other words, has a lack of oxygen saturation, would be anybody who has a pulse oximetry reading of 91 to 94. Moderate would be 86 to 90, and then severe would be anyone who has less than 85%, less than or equal to 85% oxygen saturation. So the question becomes, okay, so when do we use oxygen, right? So a patient who's in mild hypoxia or to severe would be patients that we would want to kind of use to deliver oxygen. So again, I'm just making the argument that a pulse oximeter device would be a great tool to have in your kits. So when you have patients with various levels of hypoxia, the recommendation is that the delivery device changes, right? A person who has mild hypoxia doesn't need as much oxygen to reach the normal state, right? Therefore, we are going to use devices that deliver lower concentrations of oxygen. So for a patient who's in mild hypoxia, we're going to use the nasal cannula, and then we could use the resuscitation mask. Either of these depend on whether or not your patient wants a delivery device over their face and or in their nose. But as we travel down the hypoxic state, right, and hypoxia increases, then the delivery devices that deliver the highest concentration of oxygen would then be used to restore those saturation levels to normal, if that makes sense. So you're going to be using that non-rebreather mask and or a bag valve mask. Again, my preference is always a non-rebreather mask, just because you don't have that push of air into the patient's face. So the pulse oximetry is really easy. We'll actually do it in the lab, so there's no need to explain limitations. Some factors that may reduce the reliability of pulse oximetry, so hypoperfusion and or a patient going into shock, a patient who's been in cardiac arrest for a while, because you'll have absent perfusion to the fingers, which is where the pulse oximeter is going to lay. Excessive motion during the victim at reading. This happens to my son all the time. If he keeps moving, right, then the finger loses contact, and so what you'll see a lot of times is a false positive reading, if that makes sense. So he'll look like he's either mild or in a moderate hypoxia. And so I always have to remind the physician, hey, this is a child, retake it, hold his finger while you're doing it. Fingernail polish, believe it or not, because it reduces the contact of the nail bed with the actual device. And the list could go on. The most common ones, though, would be fingernail polish for sure, excessive moving in a hyperventilating patient, and then edema, right? So just be careful when you're using the pulse oximeter. Do it on a few fingers to make sure you're getting the correct reading. All right, so how do we assemble the oxygen system? The first thing that you're going to do, check number 1, is check to make sure that it's actually oxygen, right? So the question becomes, is it green, or does it have this diamond-shaped symbol which says oxygen on it? The next thing that you want to do is you want to clear the valve. The reason you want to clear the valve is because if you don't clear the valve, then a lot of times what you'll see is an oxygen tank will just sit. And so sometimes you'll get dust mites that sit in the actual valve. And so a patient maybe who has allergies, and now you're delivering that device, you could create an allergic reaction. So what we want to do is clear the valve. We absolutely want to clear it by just turning it on for a few seconds, letting that still oxygen out, and then turning it back off. Next thing we want to do is actually attach the pressure regulator if you have a device that you actually have to assemble. So this would be the regulator that you need to attach. And again, we'll go through this in lab. Let's make this a little bit bigger. We'll go through this in lab so that you guys can actually see. What we want to make sure is that the O-ring, this right here, is going to be aligned within the oxygen tank itself. Again, make sure it's marked oxygen regulator. Want to make sure that everything is secure, and then we're going to tighten that pressure regulator down to the actual cylinder itself. We're going to open the cylinder once the pressure regulator has been attached and check the pressure. We want to make sure, number 1, that it's not empty, right? Hopefully that makes sense to you all. And then last but not least, always last but not least, once we've done everything, then we want to attach the actual delivery device. This all seems like it went fast, but trust me, I hope that this will make our lab time a lot more efficient. So when we administer emergency oxygen and we've attached the device, a few things are going to happen. Just want to make sure that I'm clear on this. The flow rates are important, right? The devices that you use should be strategic, right? A nasal cannula, again, should not go above 6 liters per minute. Some textbooks say not above 4 liters per minute. And the big reason for this is because of the increased risk of epistaxis or nosebleeds, right? So you are going to choose the delivery device. Your choice of delivery device, as I stated on the delivery device stage, is really going to depend on how well your patient's breathing and whether or not the patient actually wants you to put something on their face. Before we actually apply the delivery device to our patient, we want to make sure that we actually verify. You can see her holding this non-rebreather mask up to her face. She's verifying that, in fact, there's actually oxygen flowing. And then last but definitely not least, you want to actually place the delivery device on your patient. Big deal. Once we put the delivery device on, we want to continue to monitor, if we have a pulse oximeter on, the saturation levels, right? Because once that patient gets to about 95%, then we either want to decrease those liters per minute or remove it altogether and allow them to breathe in and to restore their own oxygen concentration or saturation levels. I hope this has been helpful. Please come to class having listened to this lecture. We will kind of maybe do some scenarios, and then we'll actually do the skill and get you guys all certified.